All right, welcome back. This is it, the final explainer in our series. We're taking all that theory and bringing it right into the consultation room. We've built the framework, and now it's time to see how the Bárány classification works in real clinical action. So in the first two explainers, we really laid the groundwork, right? We set up the four key symptom categories and that all-important axis of spontaneous versus triggered events. Well, today, we're going to deploy that framework. We're going to build a structured history that's fast, incredibly effective, and just powerfully diagnostic. But here's the thing. Before we even think about classifying, we have to screen. This is like the prime directive, the number one rule of vestibular history taking. Why? Because a red flag changes everything. It literally stops our classification algorithm cold and screams for urgent investigation. The stakes here are incredibly high, so let's make sure we get this right. Okay, so here's our game plan. We're going to turn all that theory into a seriously powerful diagnostic tool. First, we'll look at how to map a patient's story onto the Bárány categories, all while keeping an eye out for those danger signs. Then, we'll get into how to refine our hypothesis using timing and triggers. And finally, we'll pull it all together into a super practical, real-world diagnostic workflow. All right, let's dive into step one. This is the foundation of everything. It's all about listening. Really listening. And then translating the patient's experience into a precise clinical category. All the while, you've got to have your radar up, listening for any red flags that might be hiding in their story. So, first up, vertigo. The Bárány Society definition is actually beautiful in its precision. It's a false sensation of self-motion, or a distorted perception of it. The key thing to remember here is that it's not just about spinning. It's about any illusion of movement, when, in reality, there isn't any. Now, to get to that precise definition with a patient, you've got to use the right language. Just asking, "Do you have vertigo?" often doesn't cut it. Instead, you need to ask about the experience. Do you have any spinning, rocking, tilting, or swaying sensations? See? That question captures the whole spectrum and helps you avoid getting stuck on just one potentially misleading word. And bam, here's our first critical red flag. If a patient comes in with sudden onset vertigo and any neurological features, we're talking new headache, double vision, slurred speech, especially if they have vascular risk factors, everything changes. Your whole diagnostic pathway shifts in that instant. This is not a peripheral issue. You have to be thinking posterior fossa stroke until proven otherwise. Okay, next up is dizziness, and the distinction here is absolutely crucial. Dizziness is that sensation of disturbed spatial orientation without a false sense of motion. It's that feeling of just being off, but you don't feel like you or the world is actually moving. So how do you get a patient to describe this? Well, you ask about things like feeling lightheaded, foggy, or having a floating sensation. These words map right onto the clinical definition of non-vertiginous dizziness, and a yes here opens up a whole different set of possibilities, like PPPD or maybe orthostatic issues. Now, the red flag for dizziness pops up when it's paired with new coordination problems. So if a patient tells you they feel foggy and they've suddenly started stumbling or their limbs feel clumsy, you've got to immediately consider a central cause. We're thinking something like a cerebellar issue. All right, our third category gets into this really elegant dance between our inner ear and our eyes. We're talking about vestibulo-visual symptoms. These pop up when that vestibulo-ocular reflex, the VOR, gets disrupted. And what happens? The world starts to blur, bounce, or even tilt. Here's a clinical pearl for you. A lot of patients won't just volunteer these symptoms. You have to ask about them directly. A simple question like, does the world seem to shake, blur, or bounce when you move your head, can be incredibly revealing. A yes there points you straight to the VOR and can be a massive clue, especially when you're thinking about something like bilateral vestibular loss. Okay, but the absolutely crucial distinction here is when the bouncing happens. Is it only with head movement? That's probably a VOR gain problem. But if the world is bouncing when the patient is sitting perfectly still, that's what we call spontaneous oscillopsia. And let me tell you, that is a massive red flag for a central neurological cause. That needs urgent investigation, no question. And finally, we've got postural symptoms. This category is all about the real world. It's about function and, most importantly, safety. This is the consequence of a vestibular disorder playing out in everyday life. We're talking about everything from just a vague feeling of unsteadiness all the way to a history of serious falls. So the questions here are, as you'd expect, direct and very practical. Do you feel unsteady on your feet? Have you had any falls or even near falls? This gets right to the heart of the matter, the patient's stability and their fall risk, which, let's be honest, is a core part of our responsibility to manage.
And for our last red flag in this section, it's all about direction. Look, general unsteadiness is one thing, but if a patient is telling you they're being pulled or they're falling consistently to one side, that's what we call directional pulsion. Well, especially in an acute setting, that is a huge pointer towards a central lesion affecting those vestibulocerebellar pathways.
Okay, so we've categorized the symptom and we've screened for red flags. Now we can start to really refine our diagnosis. The next couple of steps are all about adding the dimensions of time and triggers to build a much clearer clinical picture.
Step 2 really hinges on what I think is probably the single most powerful question in the entire vestibular history. Are you ready for it? It's simply, does the dizziness come on by itself, or does something bring it on? That's it. That one question just beautifully splits your differential diagnosis right down the middle, separating spontaneous stuff like Meniere's from triggered conditions like BPPV.
So, if the answer is spontaneous, then step 3, duration, becomes your best friend. It's the primary discriminator. Think about it. Are the attacks seconds long? You should be thinking vestibular paroxysmia. What if they lost from minutes to hours? Now we're in the realm of Meniere's, or maybe a TIA. Hours to days? That's classic for vestibular migraine. And if it's continuous for days to weeks, you're looking at an acute vestibular syndrome, and you need to figure out if it's neuritis or, more urgently, a stroke.
Now, on the flip side, if the symptoms are triggered, your goal is to become a detective and identify the specific trigger. Is it a change in position, like rolling over in bed? That just screams BBPV, right? Is it brought on by busy visual environments, like a supermarket? You should definitely be thinking about PPPD. Every one of these triggers points you directly to a likely diagnosis and tells you exactly what to look for in your exam.
Okay, so let's put this all together. What we've built here isn't some long, wandering history. No, this is a targeted, super efficient 5-minute workflow. It's a system designed to take you from the patient's very first words to a highly specific, testable hypothesis. It's incredibly powerful.
So here it is, the whole workflow in 3 essential steps. 1. Categorize and screen. You map their language to a Bárány category while always screening for red flags. 2. Identify the trigger. Is it spontaneous or is it triggered? And 3. Establish the duration. You pin down the timing. If you follow these 3 steps, I promise you, you will generate a really robust diagnostic hypothesis before you even lay a hand on the patient.
And just like that, we've reached the end of our 3-part series. What a journey, right? We've gone from the foundational Bárány definitions all the way to this integrated clinical workflow. And I hope the central theme has been crystal clear. Mastering this language, really nailing down this process of precise classification, it is, without a doubt, the most powerful diagnostic tool you have in vestibular medicine.
Hey, thank you so much for watching this explainer from all of us at Australian Dizziness Clinics. If you're looking for more resources to support your practice, please do visit our website. And of course, if you found this series valuable, we would be so grateful if you'd subscribe and maybe leave a rating. It really helps us out. Thanks again.